that we hear you.
Sorry, that I didn't hear you. That was interrupted by recording in progress. What did you say, Dr. J?
No, just know that we hear you.
Yeah, oh yeah. Okay, I will mute myself until.
And I'm sorry about the sound that my computer might be making. It's hard if I turn the notifications off, I will be mute.
I see. Well, that's okay. We'll be all right. Do you have slides to share?
Yeah, yes, I do.
If you wanted to get those loaded up, and then I can start introducing you. I think we can get started so that you have plenty of time. Just gonna get welcome everyone to Geriatric Medicine Grand Rounds. I can see that many of you have joined already, and I know some more will be joining. We have a fantastic speaker today that some of our fellows have gotten to know, and some of you might have interacted with, but Dr. Susanne Jeffrey is a clinical assistant professor in the School of Dentistry. She is a Swedish trained dentist and has done additional postgraduate training after her initial dental training in immunology, neurobiology, as well as geriatric dentistry. And she directs the geriatric dentistry program here at the University of Washington, and all of and the 3rd and 4th year dentistry students get to rotate with her. And some of our fellows have had an opportunity to work with her over the last few years, and it's been a really wonderful experience for them, because as all of you know, we don't get enough training in oral health, in general medical training, and many different health professions trainings. So I'm so glad you're coming to speak with us today. Dr. Jeffrey also has a patient who has joined her today, who is going to be speaking after her initial talk here. So welcome, Linda, as well. Thank you for joining us.
Okay, thank you all. I'm so happy to be part of this group, and it has actually been very encouraging to have Jessie and Tiffany, and last now Sophia, with me in clinic. And I can see that we all grow when we are together and when we share experiences, because when you're in the clinic, you are there with real patients. So you see all the solutions. And for dentistry, it is especially important that you can start the preventive care, and you know what happens to the patient's teeth when you are doing certain like medical procedures, or when patients have GERD or diabetes, for example, and it really affects the teeth. What I wanted to focus on today is 2 different things. I wanted you all to meet Linda at the end, and Linda is a cancer survivor who is now with me in the geriatric clinic out in Linwood. And I wanted you to hear her difficulty in just navigating or transition from her cancer treatment in 2011. And now it is 2023. And I actually got her first into the clinic in 2022. And how all these treatments affects her teeth and just her story. But first I wanted to talk about spit or I want to talk about saliva. Because when you hear about restorative dentistry, you think it's all about drilling and filling. But your diet and everything, the medications you take, it all changes the pH, the buffering capacity of saliva, and then you're failing, or all your restorative dentistry can fail. So first, a bit about me, and you heard from Kate all those academic things. I have a husky, a rescue husky, Gambit, and a senior cat, Dottie. He's now 17. And I love to cook a lot. I love to go out to the Pacific Ocean and camp. And just this week, I actually bought an old surplus Chevy Express van from the Utah surplus auction because I plan to do more camping and hiking this summer. I love genealogy, and I've traced some of my ancestors. Even my third cousin on my mother's side lives here in Washington State. I have many relatives in Washington and in Oregon. And I have a deep background in basic science, but I'm actually really a clinician. But just to understand how to change treatments, you need to have some roots in basic science first.
Dr. Jeffrey, I'm sorry to interrupt. It looks like the presenter view is coming through. It's okay, we can see it, but if you're able to easily change it, that we can see your presenter's view with the previews.
Okay, let's see here if I can go it in another way then. Do you see it differently now? Or is it the same?
It's the same, but that's okay. We can see your
Yeah.
slides.
It is just that they are smaller and you see everything else that is distracting. Okay. I'm sorry about that. We actually checked that with Linda yesterday, but it seems okay. So last year when at graduation, I was actually able to hood the dental students together with our chair. And we have phenomenal dental students that are so interested in oral health. And they get a great medical foundation since we changed our educational program a couple of years ago. So we teach the first 1.5 years together with the medical student, at least in part. Okay, we do a lot of outreach, and I joined the students to the outreach to the refugees and the trafficking survivors, and also we go to Homage in Linwood, which is a senior center, and we also go have a geriatric clinic in Longview. Okay, so today I wanted us to focus on the areas in medicine and dentistry that kind of merge when we treat our geriatric patients. There are so many medical conditions that affect dental treatment. And as a dentist, I see when we have high blood pressure patients, I need to change the local anesthetics that I give. Sometimes I cannot treat the patients if the blood pressure is 160 over 100, that's the top. If it goes to 180 over 110, I can only do emergency treatments. So many times we have actually sent patients to the emergency care. So just a heads up here, I think you are able to accept higher blood pressure in medicine, but when patients come to the dentist, their blood pressure is usually higher. And then if I choose anesthetics with adrenaline, I will raise it maybe even up to like 15 to 30 millimeter mercury just by one injection. I can also use plain, but just know that in the dental chair, all the blood pressures go up because it's not the patient's most favorite thing to do. Other medical conditions that affects dental treatment is artificial heart valves, joint replacement, and then we give antibiotics at least for 3 months for joint replacement before every dental treatment. We have a lot of patients that have gone through transplantations. And Linda, that you will hear from today, is a cancer survivor, and she has received radiation and chemo, and especially radiation. She had tonsil cancer, so it affects her bone, her teeth, and her salivary glands, especially at the most radiated site where she received like maximum dose, but she got 20 to 30 gray also in the anterior part. So that also affects what treatments I can do, and I shouldn't really extract teeth at that point. So we need to do a lot of modifications. We also have diabetic patients and GERD patients. So I need to know the A1C of my diabetic patients, because as soon as I see tooth mobility, I know that the PDL, the periodontal ligament, has started to break down. So on some of my diabetic patients that cannot control their blood sugar, I need to extract teeth because they get abscesses. So for me, if I can have an A1C around 7, I'm very happy. I notice if it goes up to 8. For GERD patients, I see lingual erosion on their molars. I can see the pH of their saliva is affected. They might not have buffering capacity. Even if they are on medications, they might have enough of reflux, so the buffering capacity in saliva is saturated. And that also affects their decay. But what I wanted to focus on today was actually the salivary glands. So medications affect salivary glands through giving us like less fluid and less protein secretion. There is always a question if we can get an altered pH through medications and altered buffering capacity, or if that is only connected to the diet. And that is still a question mark for that, but I will show you the consequences that it has on the patients. And then, of course, we also have bisphosphonate, but that should we probably talk about in another presentation. It might be a bit controversial, like can we extract or can we not extract? And I have done both. Sometimes I can extract teeth on patients that take bisphosphonates, and sometimes I shouldn't. Okay. So geriatric dentistry is a lot about nutrition, dietary guidance, preventive care, and saliva assessment. And that is totally something that both Jessie and Tiffany and Sophia could embrace, that could be part of their primary care as medical providers, at least start to see and guide their patients, and also to connect to the dental community. As we age, we can get metabolic changes in salivary glands, especially for females when the estrogen levels drop, because we have steroid converting and enzymes in salivary glands. And we have also seen in Sjögren's syndrome patients, to see, maybe I can change like this. We have also seen in Sjögren's syndrome patients that they had mutations in one of those steroid converting and enzymes, and that was part of the syndrome. Otherwise, teeth don't age in a way. Enamel is dead. Salivary glands usually don't lose secretion if you don't start to take medications. And here in teeth, we have qualitative changes, especially in dentin, because it's so soft. Dentin is like bone. It is like 60 to 70% mineral, and the rest is proteins, and mostly collagen. So how medications affect the signaling within salivary glands? It goes to all these normal receptors, because we have alpha and beta adrenergic receptors and the cholinergic ones. And then we also have the same crosstalk as you see in other cells, like calcium signaling, that leads to fluid secretion, but it also is a crosstalk to the pathway that leads to protein secretion. So we know that medications, especially anticholinergic medications, decrease the fluid transport. Diuretics decrease the fluid transport. We don't know as much about how the adrenergic receptors, how they affect maybe the packaging of the proteins in the vesicles. So that is still a great field for research. So since I took over the geriatric program, I've started to do much more of saliva testing. And we have actually had saliva labs for the students when they start the first year, so they will get used to using that as a tool. So first you look at hydration. You turn the lip inside out and you see how well it can rehydrate. And that will give you a first sign if you have a patient with low salivary flow. If it takes over a minute, the salivary flow is low and you probably have a high caries risk patient. Then we look at how much saliva you can secrete, either just normally resting saliva, which is unstimulated, or if you stimulate it through chewing. And we have candle wax that the patients are chewing. So it is just the chewing by itself that stimulates saliva secretion. And then we let the patient collect the saliva for 5 minutes. If they are very dry, we might need to collect over a longer time. And if you want to use your results for science, you need to collect the samples if you want to repeat these collections at the same time, plus minus 2 hours, just because of the circadian rhythm, that salivary flow changes during the day. We look at pH and we look at buffering capacity, and I will show you normal values and also some from our patients. We haven't yet measured specific enzymes, but that is interesting. We just need to have the right biomarkers to see, for example, if there is enough calcium in saliva, so that the patient can remineralize the teeth. So why is this so important? Well, I think most dentists know that there is a critical pH where enamel will go into solution and you will start to get a cavity. And that pH is pretty low. In the literature, you find 5.2 to 5.5. And it's so low just because enamel is highly mineralized with hydroxyapatite. If you go to cementum, and this is much less known even among dentists, there is a much higher pH where the root surface will start to dissolve and demineralize. And that is very close to neutral pH, 6.1 to 6.5. And most of our foods that we eat are at that pH or lower. So once you have some bone loss, you have some erosion, maybe some attrition from brushing hard, and you start to show the root surfaces, you can reach that critical pH for dissolving of the cementum very easily. And this is the real problem in geriatric dentistry. You can also see here on the root here that the covering dentin is not as thick as what covers the crown and the nerve up here, enamel and dentin together, which means that the exposed root, you have about 2 to 3 millimeters before you come into the nerve. So if you have root decay in this area here, you might need to even extract the tooth. So that's why it's so important to catch this. If we look at caries throughout life, kids get caries on the chewing surface. Young adults start to have caries on the surfaces, like in between the teeth. When we get to the middle age, 75% of us have lost a tooth. And then usually at 60 plus, then we start to have root surface caries. And these high caries risk patients that develop caries have many common features. Most high caries risk patients take 4+ prescription drugs. And the patients that I will show you in the next slide set, they actually take 7 medications each. And it's to lower cholesterol, it's for blood pressure, some might be pain medication, but 7 medications each. Some high caries risk patients have also gone through chemo and radiation therapy. And what I find when I do the saliva testing, what is most common is that they have low unstimulated flow and low pH of the unstimulated saliva. Which means that, like now, when we are sitting here and just being still, that is the saliva that is in your mouth right now. So if you have a low pH of your unstimulated saliva, then your teeth can dissolve just during this time. So that's why it is so important to stimulate saliva, because then usually the pH goes up. Also, you need visible plaque, and it has been shown that if you have recently lost a tooth, it's your habits or something in your habits that could change so you don't lose another tooth. So if you have recently needed to extract a tooth due to caries, you have a higher risk of losing another tooth. And then, of course, exposed root surfaces and diet. It's not only sugar, it's sugar consistency and pH that is important. Okay, so if we look at some typical x-rays that shows caries in older adults, and we can call these patients Stanley and Pam. And as you see here, there are restorations here where the x-rays are stopped, is a gold crown, amalgam. Here is a resting crown. And here you can see where the yellow arrows are, exactly where the demineralization is starting. So for Stanley here, it's right underneath his previous restorations in the margins, and they are at this root surface. All of these cavitations or first demineralizations that will give a cavity starts at the root surface. For Pam, that's the same. So the enamel can be fine, but as you age, this is what is so fragile. And here underneath the amalgam filling, and you can see here is another view of the same tooth, both on the back side, the distal, and the front side, the mesial, is cavitations and demineralizations. So either here we could do root canals, or we might need to extract if the lesions has gone too far. So what is important when you do geriatric dentistry is that you get caries control. We can do a lot of bridges and we can do a lot of dentures, but if the patient is continuing to get decay, then all of these treatments will fail. So here's where saliva testing comes in, because we want to create preventive care programs that are as personal as possible, so they really address what each patient needs to know, and depending on the medications they take, how many root surfaces they have exposed, what areas are difficult to brush, for example. So we look at hydration, we look at the unstimulated saliva, and we look at and measure the stimulated saliva. Here is how we could measure hydration. You see on the surface, the saliva from the minor salivary glands that are just scattered throughout the oral mucosa. So we wipe the inside of the lip off, and then we wait a minute and see if another drop is able to form. Because most patients, and usually students and me as well, we don't hydrate enough. I don't drink enough water throughout the day. Then we measure unstimulated saliva, and this is how I measured mine. So I was sitting and just drooling into a cup, and instead of measuring with the pipette, it's better to weigh it. It's much more adequate. So 1 milliliter weighs 1 gram. So here you can see I produced 3.5 milliliter in 5 minutes. So my flow is 0.7. Here is when I measure my stimulated saliva, and you can see this is much more. And it has a much higher pH. If you remember from the previous slide, my pH was around 6.8, almost in the yellow, but here I'm at the highest. So that also means that the advice we give to many of our patients is to eat a more raw diet. So you chew more. The more you can chew, and the higher your flow, you also get the higher pH and also higher buffer capacity. Then I measure the buffer capacity of my saliva, and there are commercially available strips. So you know if your saliva is able to convert acids that are dried onto that strip. And my saliva, here there is a scale. If you do this for scientific studies, of course, you will need to titrate instead. But you can see that I have the maximum buffer capacity. Many patients, and especially GERD patients, do not. And this patient was actually a GERD patient on medication. So she thought that she was fine, but she doesn't have enough buffer capacity in her saliva to convert the acids on the paper strip. So that means that she still needs a lot of preventive care to keep her teeth. So here is in a table format. And here is the dental students, and you can see they beat me a bit. And actually, when we did this lab, the male students, they had a contest, like who could secrete the most saliva. So they had secretions up to over 2.6 milliliter per minute, while mine was 1.7. But you see, all of our values here are in green. They are normal. We don't take any medications. We used to measure how much strep mutants we were able to grow, but everyone was positive, so we excluded that test because it was too sensitive. If you start to compare these values with one of my patients that is high caries risk, and that I saw in the geriatric clinic, you can see the difference with her secretion. It's almost non-existent. And the pH was also very low. And this means that she is basically dissolving the root surfaces of her teeth all the time. The stimulated saliva was also low. And then we missed to measure the pH at her appointment. For some reason, the buffer capacity was still normal, and I cannot explain that. Then here you have some values from one of my diabetic patients from my faculty practice. And her diabetes is not fully controlled, so she will have a higher sugar level surrounding her teeth all the time, and she develops decay. So as long as these parameters are not controlled, then you know that you cannot invest in inexpensive dental appliances because they will eventually fail. For my last patient here, my diabetic patient, I have needed to do mostly crowns instead of restorations. So you need to modify your treatment. So if we look at Stanley and Pam, because they had very different outcomes of their saliva test. If you remember Stanley, so they both took 7 medications each. They both have the same like secondary caries underneath the restorations. But for Stanley, the test came out normal. His saliva was great, and we couldn't figure out why he developed so much decay. So it took a while, and then he finally admitted that, that he was eating a lot of sweets, and he was eating a lot of very sticky carbs. And now we can start to do his appliance. And that's in a way that he can change, because he has so many, if you can see here, he has so many restorations, and this is his front teeth. So you also basically need to place crowns here just to protect them. If we look at Pam instead, and they both had the same medications, but she had a bit more pronounced decay and developing decay underneath her restorations. And it almost looks like a mouse took a bite here. Her values were very different. And she had a low flow, she had a low pH, and a very low flow of her stimulated saliva. So here, and you can see she has also lost more teeth. And it is harder to help her because you need to change almost everything in her habits. So this means that she is closer to receiving full dentures than what Stanley is. But if I don't know this, I cannot help them with the right preventive care, and I don't know the outcome of my treatment. So when we want to care beyond our restorations, we need to do saliva assessment, assess patients for caries, do more nutritional counseling, and then the preventive care that they need. And I will talk more about that soon, because we want to create appropriate dental treatment plans that have a more sure outcome. We have needed to look more at the nutritional aspects, and medicine has done that for a long time. I still remember when there was a nurse that asked me, well, what is a tooth-friendly diet? And I had actually never considered that. So a tooth-friendly diet, I would answer, it's more sugar-free. You use xylitol as much as you can instead of sugar. But you'll also look at the pH and the consistency of your food. So we are trying now to create more personalized preventive care programs so we can increase the quality of care. So I put together a 9-page pH chart for my patients that I dispense. And I have highlighted here the ones that have a higher pH that goes towards 7 or at least 6.8. And when you go through this, you see that most of our foods are acidic. Of course, especially the fruits, but most of what we eat is acidic. And if your saliva doesn't have enough buffering capacity, and you are also growing an acidic biofilm, it's a battle that is hard to win. If you change your diet to be more plant-based, you increase the pH of your saliva tremendously. Consistency is key. And you can see this is from a nursing home patient that doesn't get help with brushing. And you can see her, or you can see the gingivitis. I'm sorry for this. You can see the gingivitis, the red parts surrounding her teeth, and also the stickiness of the food. Most nursing home diets are very soft, easy to chew food. So the strategies that we use is to strengthen and to compensate and to reduce sugar and try to reduce bacterial growth. So you strengthen enamel and dentin with high fluoride toothpaste, prescription toothpaste, which you as a medical professional also can prescribe. You want to aid in remineralization. So some of these toothpaste also contains calcium, because if you don't have enough saliva is usually super saturated with calcium. But if you don't have enough saliva, you don't have enough calcium to remineralize the teeth. So that's why on the market, there are also some calcium containing toothpaste. Then to compensate for loss of saliva, you need to stay hydrated. There isn't any artificial saliva. I thought when I started dental school like 40 years ago that there would be lots of artificial salivas around by this time, but there isn't. It's hard to create a solution that should contain like 2,000 proteins or peptides that would mimic saliva. So the best advice, and I gave my patient, is actually to choose xylitol gum and to eat the more raw diet, so they secrete more of their own saliva instead. You can lubricate the oral mucosa with an oral balance gel. And in Europe, there is an oxygenated oil that will relieve the mucosa from feeling that much pain if you are super dry. It was sold on the US market by 3M, but then when I wanted to order it, they had withdrawn it from the market. There might not have been enough demand. Then you can compensate for loss of buffering capacity with rinsing with baking soda, like 1 teaspoon in a glass. And then, because that gives you a pH of about 9. So after you have eaten, you can just rinse with baking soda water, and that will help you to more easily or faster neutralize the acids in your food. Trader Joe's and also Trader Joe's sells a baking soda containing toothpaste and Arm & Hammer. Most of their toothpaste contain baking soda. It's also good to know that the Seattle tap water actually is aiming towards a pH of 8.2. So there is no use in buying carbonated water because most of it is acidic. If you look at Perrier, it has a pH of, I think, around 5.2. So it's better to drink filtrated Seattle tap water. You can also compensate for loss of buffer capacity by changing your diet to foods with a more neutral pH and eat more raw food. So you chew more and secrete more saliva. It has been scientifically proven also that xylitol, which is a sugar alcohol that bacteria, the oral biofilm, cannot use, that will actually inhibit root surface decay. It doesn't change enamel surface, but for our older patients that have exposed root surfaces, this is what we recommend. And we have a very diluted, like chlorhexidine rinse that is on the market either with alcohol or without, that we also recommend for high caries risk patients. So 0.12% chlorhexidine. There is also varnishes that contains chlorhexidine that we can paint on the root surface so that bacteria cannot aggregate. So this is all these things, and some of these are easily available for medical professionals to just utilize and to recommend to patients. Here is a handout that I usually give my patients also, so they see what I would recommend if they are low caries risk versus moderate risk or high risk, and what I can do for them and what they need to do in their own home care. Here are some references if you were interested, and just feel free to email me at any time. And here is Linda. And those are photos that we actually took in the geriatric clinic this Wednesday when she was there.
Yeah, after I've been standing on my head for 3 hours and having my mouth drilled.
Okay. The podium is yours.
Thank you. Okay, the first thing I want to say is I want a copy of this lecture because I needed this about 13 years ago.
Yeah.
Yeah.
She working on a book?
So, can you hear me?
Yes.
Okay,
Yeah.
good. So I'm going to read this because I have a lot to say and I got to get it done in just a few minutes. This is a story of medical dental dysfunction that should not be in this, the richest nation on earth. 13 years ago, at the age of 64, when I was diagnosed with squamous cell carcinoma of the tonsil, I was healthy and very fit. I danced about 30 hours a week in classes, along with students at the UW dance program, sometimes helping teach some of those classes, in addition to teaching classes and private students of my own. While I created my own program of study in the history and ethnology of American popular music and dance. And I had a mouthful of healthy, fully functional teeth, including all of my wisdom teeth, except for one, number 3. So I'm right up there with you. I lost one tooth in middle age. I had a wonderful dentist on Bainbridge Island where I used to live, and I trekked back there from Seattle for my dental care because he was so good. When I was diagnosed, UW Medical Center and Fred Hutchinson literally saved my life. And it was a fight, not against them, but with them against the cancer. They told me treatment for the head and neck cancer I had was the most rigorous treatment there was, except for bone marrow transplant. They wanted to put a JPEG tube directly into my stomach to feed me because they didn't think I would make it without that. When the surgeon told David and me that my stomach would likely fuse to the abdominal wall as it healed, I refused the surgery because that meant I wouldn't be able to dance. My radiologist, resident, and nurse hotboxed me, closing me in a windowless room, and they tried to scare me into agreeing to the surgery. I refused again. They told me big, strong men had not been able to survive what I was going to endure without a JPEG. I still refused. So they hung a nose hose on the back of the exam room door, fully expecting me to come begging for it when it was too late for surgery. For nearly 4 months, 4 times a day, David, I'm going to cry, sorry. David stood at the kitchen counter with me and willed me with silent patience to take one more swallow as I cried with the pain of each of those swallows. I never asked for that nose hose. After completing the cancer treatment, the medical resident told me I had a mouthful of teeth if I could keep them. He prescribed a teeny tiny, outrageously expensive tube of 1.1% fluoride toothpaste and told me to brush my teeth for 10 minutes at a time. It took me months to be able to even pretend to brush my teeth, even with a silky, soft baby toothbrush, because my mouth was so sore. The resident also referred me to 2 possible dental clinics, an off-campus dental clinic where I'd been sent for cancer prep. That experience had been so traumatizing that I refused to set foot in their door. The other choice was the UW School of Dentistry, but something in his tone, his words, his body language, I can't remember what, left me with the clear sense that the School of Dentistry was not very good and I shouldn't go there. So I had nowhere to go, and I wandered in the dental wilderness while my teeth disintegrated. I complained to one dentist that I was eating my teeth. He said he'd never heard that before. And while he had said that he was familiar with post-radiation care, he had absolutely no idea what to do, and I got no preventive care from him. For 9 years, I wandered that wilderness while my teeth disintegrated in my mouth. I was working 80 hours a week, traveling out of town every week to take care of my granddaughter, home only on weekends, exhausted and still working because I had my own business to keep up. As of today, 13 years later, I am missing 12 teeth, 6 of them completely, 6 with embedded roots that can't be removed because of the risk of osteonecrosis of the jawbone due to radiation. I don't know how many other teeth I'll lose before this fight is over. The worst part of this misadventure is that it didn't have to happen. Oh, sorry, it didn't have to happen. I experienced 2 failures of care during transition from cancer treatment to cancer survival and life after cancer, which I believe were largely responsible for the disintegration of my teeth. And that's why I wanted to talk to you. But first, you need to know what has been working since I started working with Dr. Jeffrey. First and foremost, I found her 4 years ago, just before COVID. Dr. O'Connor in the UW School of Dentistry suggested that I might be interested in participating in saliva testing that she was doing. I was, and I learned a lot, and I learned a whole lot more today. In a nutshell, here's what has been the most helpful: the saliva test. I learned that my body is slightly alkaline. I eat right. And though I have dry mouth from the radiation, I have sufficient saliva to protect my teeth, though it's thin and watery, drains out onto the pillow at night. I learned that chewing activates saliva through the movement of teeth in the gums, pumping saliva into the mouth. Hence, I chew, which I'm doing right now. And I chew this gum, ice cubes. This is an advertisement, a commercial with the xylitol in it. I chew it during the day, especially when I'm teaching or exercising, or when I have to talk to somebody like you guys now. I also use xylitol lozenges.
Yeah.
Xylomelts.
Those are great.
Yes. I stick one inside my cheek and it stays there. It doesn't go down my throat, and it keeps my mouth moist all night long. I also use alkaline drops. I boil the water I drink and put these drops in it to raise the pH. And I sip that water all day long, although apparently not enough still. I'll get better. I also use colloidal silver. I swish my mouth out with it to kill bacteria a couple of times a day. Probably I should do more even. Knowing all this, the condition of my teeth did not make sense. Are you going to tell them what my teeth look like?
No.
Okay, well, they're about like Pam and Stanley. So we looked further. She had me pH test everything I put in my mouth, and that was critical for a period of about a week. And that's where I found 2 culprits. Obviously, because of what I've learned today, I know there's more going on, but there were 2 culprits that were contributing. The first one was Arnica montana pellets that I used for years, putting them under my tongue at night. Oh, I didn't bring those. Putting them under my tongue at night to reduce the pain from a dislocated loose SI joint so that I could sleep. As a dancer, I'm very aware of my body. I knew I wasn't as strong after cancer as I had been before, but I received no guidance whatsoever about how to transition safely back into my pre-cancer activities. As a result, I took 3 falls on the dance floor and a 4th fall in the pitch black dark where I couldn't see the ground coming up. I'm a dancer. I already said that. I know how to save myself from falling, and I know how to fall and not get hurt, and I've done it many times recently. Before cancer, none of those incidents would have resulted in a fall, or if I did fall, in an injury. Arnica montana is a natural homeopathic product, one I had used before cancer with no problems, but the pellets have sugar in them. I was soaking my teeth in sugar on a nightly basis for years. Yeah. The second one was biotin spray and the mouth rinse. These were recommended to me by several dental office personnel. I used the spray 3 or 4 times a night, every night, so I could keep my mouth moist, again, for years. It was demineralizing the tooth enamel because it's acidic. When I did the pH test, I discovered that. I didn't know that before that. I stopped using it, and that's when I switched to the Xylemels, which are not acidic. Cancer was hard, really hard, but I'm a fighter and a survivor. That fight I won, we won. David has been, my husband, who is sitting over here and is camera shy, has been in this with me every inch of the way and right up to today, as he comes to my dental appointments and stays with me through the long, difficult hours of restorative treatment that I'm receiving from Dr. Jeffrey and her students at the Lehigh Geriatric Dental Clinic. And difficult and exhausting as those treatments are, I would be toothless, dying, or dead, or David and I would both be homeless, bankrupt, and living under a bridge without that clinic. There is no way we could afford the cost of these treatments. The thing is, it shouldn't be this hard. I shouldn't need such extensive treatment, and we shouldn't have been put at such financial risk. A more functional medical dental system would have prevented that. First, dentistry is medicine. Medicine is dentistry. Oral medicine is a word for dentistry, a medical specialty. Doctors and dentists have to work together for the sake of patients. That means all you out there that I'm talking to, need to understand each other's professions enough to be able to communicate and cooperate with each other. You're on the same side of your efforts to help your patients. Educate yourselves and work together. Anything less and your patients suffer. David is a physicist. I'm a well-qualified scientist. I'm a teacher. I've been teaching for 60 years in the classroom, on the dance floor, and in life. We're relatively sophisticated consumers of medical and dental care, but we could not protect ourselves from the dysfunction of faulty transition of care on 2 fronts. Cancer to getting back to living, and cancer to post-cancer dental care. Second, together, doctors and dentists must educate your patients. And I learned this even double more today with what you said, Dr. Jeffrey. You cannot give us random instructions or prescriptions without understanding us and our lives beyond care, because we have stuff going on. Or explain the background and reasons to why and how what you're asking us to do is going to be useful to us. And then after that, without doing that, expecting us to cooperate or become active participants in our own care, which obviously is critical. And you have to understand who you're talking to and how they learn. In all those years that I've been teaching, I have taught 2-year-olds, 10-year-olds, 20-year-olds, 40-year-olds, 80-year-olds. They all learn differently. You have to know how to teach your patients so they can learn. And that's the end of my rant.
So something that I didn't say is that the Lehigh Clinic out in Linwood, it is a community corporation. It's a community-based clinic that is free for the patients. I started to treat Linda in my faculty practice, I would totally have, she would have gone bankrupt with the charges and the fees that I need to charge, and there's no way I can get away from that. And her treatment goes beyond what Apple would reimburse as well. So at Lahai, it is a grant supported clinic where we can treat the geriatric patients that are in need and that cannot afford. And priority also for homeless patients. And you need to apply, and it's income related. But I also make exceptions for when it's really needed. Of course, it is a struggle to keep that clinic. I fight administration all the time because it pays for our expenses, but it might not cover like direct costs for everything. Okay. We still have 3 minutes left.
Thank you so much, Dr. Jeffrey, and especially Linda for sharing your story. That was amazing and really inspirational, and shared so much that we all need to hear. The biggest question coming in is if we can get the contact information for the clinic up in Linwood.
Yes.
The best way to reach
Yeah.
that.
Do you want me to give it here, or can I give it through email to you?
Either way is fine. I think Tiffany put it in, is it the lahai.org website?
Yeah, they have two different clinics, and this one is on Schreiber Lake Road. And I wanted our residents to be able to rotate through that clinic. Lahai is open to, if I have asked them to make some type of agreement, but there we treat dementia patients, like early dementia patients. They're very complex, like medical patients, and you will see a lot of community dentistry at its finest. We can actually mill crowns in house through 3D printing.
That's amazing. We probably have time for one more question. Stephen is asking if xylitol is the only sugar alternative that isn't digested by the plaque forming bacteria.
I think erythritol has a monk fruit. Xylitol is scientifically proven. Sorbitol can be used by bacteria. So bacteria can convert to use that sugar alcohol. Erythritol, I think, is safe as well.
Is there time for one more question?
Oh, Tiffany had a question, and then we might have time for Barbara's. Tiffany's wondering if you can say how patients should do the saliva testing, the pH test, and not the pH testing for food. I'm sorry.
So on Amazon, so of course I buy these things, right? So on Amazon, you can buy rounds of pH paper, super inexpensive. Yes, they go from 1 to 12, and I just bought them and I just dispense them to my patients that needs it. And then they can test their liquid, their foods. And that's the only way I found to do it.
Fantastic. Well, we're at 9 o'clock. I bet there are a bunch of other questions. If anyone has a question, you can email it to us and we can get it to Dr. Jeffrey to answer. And if we have common questions, we can send it out to everyone. Would you mind sharing your slides with all of us? Could we?
No, of course not.
Okay,
Of-
so we'll send
of
those
course
out
I
as
will.
well. But thank you everyone for joining. For those of you who are staying on for the division meeting, we're going to be using the same link. So
Great talk.
thanks
Others.
everyone. Yeah, thank you so much, Linda, and thank you, Dr. Jeffrey. And in just a minute or so, we'll be starting the division meeting for those of you who are staying on for that. Thanks
Okay, so-
everyone. Have a great weekend.
So So then let me go and stop share here.